Everybody. Apology for the little bit change in our today's program. Due to some unavoidable circumstances, our a scheduled speaker couldn't make it. So I'm taking this lecture, and it is a very useful lecture for the intensive care as such, whether it is it comes to doctors, junior doctors, senior doctors, nurses, technicians, respiratory therapists, all are having a relevance over there. As we know, when we talk about the ventilation, the major part is like a life support. Ventilator is like a life support. It's a matter of breath and death most of the time. And of course, the certain disease is treated with the ventilation. So that's why the decision to ventilate the patient is mostly clinical. In this lecture, I would give you a very, very basic about the ventilation, little bit about the mechanical ventilation machine itself, and a simplified way to understand the modes of ventilation. So what major change happens, and what is the mechanical ventilation machine? How you can actually define this machine? So mechanical ventilation is delivery of breath is by positive pressure during inspiration. So that's a very important point here is what we are talking about the mechanical ventilation, artificial ventilation. It is a positive pressure during inspiration and simultaneously work of the respiratory muscle is actually offloaded from patient to the ventilator. So the mechanical energy required for the inspiration, this will be done by the machine. So these are the two important features. Now this machine is having a classical steps, you can say, or phases rather than. So these are the phases. A common is the one is the initiation, termination of breath by machine, and in the some mode it is determined by the patient himself. So that is the very, very, you can say, a major foundation of the mechanical ventilation. There are the different phases we'll discuss subsequently, and the major change happens from negative pressure inspiration to the positive pressure inspiration. So what happens in mechanical ventilation? The positive pressure from the airway becomes more positive and come back to the less positive, not negative. Whereas in the spontaneous breathing patient, the initial part is the negative pressure inspiration. So we take the breath, it is a negative pressure is created and eventually comes back to the normal. So that from normal to the minus and again the normal. Whereas in positive pressure, from some positive to more positive and come back to the positive. Now the question comes, how you can define mechanical ventilator? So if we want to define the mechanical ventilator, so there are the three keywords which I highlighted here, and how we can make a meaningful definition. A mechanical ventilator is a machine that generates pressure. So that generates pressure necessary to cause a flow of gases that increases the volume of the lung. So first thing, they are generating pressure. And what this pressure does, it actually flows the gases from ventilator to the lung. Eventually, the final thing is certain volume of the gases to be delivered into the lung. So that is the sequence. It produces pressure necessary to cause a flow. How much pressure? Then at least it reached to the flow. And this relationship between pressure, flow, and volume is expressed by equation of motion of the respiratory system. So that is again very, very principal concept or mechanical ventilation is what we call equation of motion, where the pressure actually having a two component. I'll subsequent slide, I will discuss the why two component, because we are not directly blowing air into the lungs directly. There are the certain tubular structure. So there are the certain tubes over there. They also require some pressure to transmit the flow. So therefore, the initial part is the resistance into flow. That is also required. And eventually the volume reaches over there. Once the volume reaches to the lung starts expanding. So how easily they expand or how tough they are expandable, this quality is known as compliance. So if they are more rigid, then you require more pressure, or the same rigidness, if you require the more volume, then you require a more volume. So the equation would be a resistance into flow plus volume divided by compliance. That is the equation of motion. And this is a illustrated diagram for simplified version. That doesn't mean this is the one trachea only. We take every tubes, we just make a one tube only. So just for understanding. So in our natural passages, we are having a trachea, bronchi, and the second degree bronchioles and all these things. So all tubes, they are carrying gases to the lung. We represent with the one tube, that is this one. And of course, it requires a certain pressure to transmit over there, just to transmit. So that is called the flow into resistance. How much pressure it is required depending upon the how narrow they are and how fast you want to traverse. These are the two determinants over there. Suppose you want to give a more air to over there, then you require more pressure. It's less, then the less pressure. And another variable is if you are having a more dilated this larger caliber of this tube, the tube will require less pressure. So even the same volume, if you just increase the diameter, you require a less pressure, or other way around, if you decrease the diameter, then you require a more pressure with the same flow. So these are the two variables. And the second variable is volume and compliance. And this structure is balloon-like. This is the extendable. So therefore, it would be like this one. So these are the two things which, and what is the clinical implication of this thing is, whatever pressure related to this system, initial part, resistance, that determine your P peak. So that is the pressure, peak airway pressure. And the pressure which is constantly is being applied during the inspiration and responsible for the expansion of the alveoli, this is called plateau pressure. And that's why the lung condition directly is actually represented by the plateau pressure, whereas the resistance is represented by the peak pressure. And this resistance, because it's from the ventilator, so even your endotracheal tube comes into this tubular structure. So same thing is, everything is same. If you are having a less diameter endotracheal tube. Example, same patient, just to understand, you change 8 number endotracheal tube into the 6 number endotracheal tube. So you will have a peak pressure high, but plateau pressure would be same with the same tidal volume, because you are having a more resistance, but rest of the lung is same. So that is the basic principle over there. I have you understand, and this is the major foundation for our ventilation and how the pressure changes and what is the meaning of change in the pressure. Suppose somebody say only the peak pressure changes and plateau same, then there is a problem with the airway. And if plateau pressure increases, definitely once the plateau pressure increases, the peak also increases. It can't happen the peak without increase in the peak. The plateau in isolation will be increased on the same condition. Then definitely it would be a problem with the alveolar level. Now, as I told you in the beginning, there are different phases of ventilation. So A phase is the initiation of phase, which is called the triggering point. B is the limiting point, how much upper level your breath will reach. And C is conversion from inspiratory cycle to expiratory cycle, which we call it as a cycling. and D is again the initiation. So triggering, limit, cycling. Triggering, limit, cycling. That is the classical sequence over there. Okay. Now coming to the mode of ventilation. I just compare the mode of ventilation in terms of the Hindu history. There are so many god and goddesses. Each god is having their unique strength and weakness and unique property. And every god is having their own way of worshipping. So that's why like in the mode of ventilation, that doesn't mean one mode is superior to the other mode, but whatever you are using the mode, you must know their strength, weakness, and way of worshipping. So now coming to the our gases. So basic, when we deal with the gas, we are having two options. Either we can measure the gas in the volume or in the pressure. These are the two major things over there. If we want to keep the pressure constant, then the volume is variable. And if we want to keep the pressure constant, then if we want to keep the volume constant, then the pressure will be variable. And if we want to keep the pressure constant, the volume will be variable. That is so whatever you can deliver to the patient, either in the measurable quantity. So either you can measure in the terms of volume, 400 ml or 500 ml, or in the pressure up to this level for this time period, I will allow to guess the pass over there in the terms of the pressure. Like when we get fill the CNG in our motor vehicle, so they don't measure in terms of the volume. They just keep the pressure a limit over there, and eventually later on they convert this pressure into the volume. So at this moment, everybody is clear. Whenever we give the inspiration, either we give in the form of the volume preset or pressure preset. That is the basic understanding of the subsequent slides for mode of ventilation. So what we are doing now, we are keeping the volume one thing and the pressure one thing. And the next thing, how the ventilation is started, based upon that, we understand the different mode. So everybody must be clear at this point. So either we can deliver breath by the measurement of the pressure or volume. So either or. Okay. Now further, how we can understand the mode. So I made an analogy for the understanding of the mode, just to imagine the scene. You are having some room or quarter, you can say, in the some campus over there. So you are residing in this, and this campus, little bit far away, you are having a cafeteria and little distance over there. Okay. So you need a water from the cafeteria, they deliver it to water to. So one delivery boy comes and deliver to the bottle to you. So one agreement with this cafeteria is you will get 1 liter of water every 8 hours. Say for example, the time would be 6 a.m., 2 p.m., 10 p.m. So every 8 hours, 1 liter is coming. That is your agreement with the cafeteria manager. There is no participation of this delivery boy. This is called controlled ventilation. That means controlled ventilation is purely time triggered. Who is actually giving the command to reach over their time? So they will deliver at the 6 a.m., 2 p.m., 10 p.m. So this is called control. And if I'm now coming to the ventilation, so same thing, it is a control when delivery of breath at the fixed time. When this delivery of breath is in the nature of preset of the volume, it is called volume control. And if it is in the preset form of pressure, it is called pressure control. Okay, you understand both the things. Now two mode you understand: volume control, pressure control. In volume control, volume preset breath with the time triggering. Every time, the time is the only triggering, because they just see the time and deliver up to, there is no interaction between you and nothing kind of. The same way, if we are deciding this much amount of pressure will give according to the fixed time, it will be a pressure control. Okay, so you understood the two modes now. Now, because this agreement, sometimes you may become a little bit restless. You may require in between water, but it is not available. So that restless in our a ventilation setting, we call it as a asynchrony. So technically, this is a very, very older form of modes. Now, no ventilator is having a volume control and pressure control, though they mention it, the name is the volume control, but actually they are not in control. What they are mode, I'll explain in the subsequent part of this explanation. So when you become restless because you are not getting when you want, of course you decided 8 a.m., 6 a.m., 2 p.m., 10 p.m., but so what you make a one arrangement, you apply a alarm over there. So this alarm key is in your room, and at cafeteria, whenever you press this button, cafeteria will have some alarm system over there. Now the agreement, second agreement. So second agreement, what was your previous agreement? Every fixed time interval, you will get a 3 bottle, like 6 a.m., 2 p.m., 10 p.m. Now you were, with this arrangement, you said, I make a little change over there. Let 3 bottles comes at the fixed time interval, but in between, whenever I want, I press this button and the additional bottle will come. This is called assist control. And suppose you don't press any button, then anyway 3 will come over there. So what is triggering over here? Time is the triggering, because 3 bottle anyway come at 6 a.m., 2 p.m., 10 p.m. But patient triggering is also there, because now you participate out of your pre-agreement. Whenever you push the button, every time it will come. This is called assist control. Again, when the nature of breath is in the volume preset, it will be a volume assist control. And when nature of breath is in the form of pressure preset, it is called pressure assist control. Now, in nowadays, all the ventilator you are seeing, immaterial, they name it as the volume control or CMV or IPPV. They all are volume assist control. And similarly, all pressure control are actually pressure assist control. Though they name it as a pressure control, but all are having the ability of this arrangement. What arrangement I told you? The participation of patient for triggering the breath, in addition to the fixed time interval. Okay. What problem can happen with this thing is the problem happens sometime you keep on triggering, you want water, but when the water comes, you feel this 1 liter is too much. It should be less, but once it is comes, you have to drink it. There is no variation between your fixed time volume of the bottle or the carrying. Exactly the same bottle. The moment you trigger that, it will come and you have to drink it. So what it can cause a problem? Over drinking may be there. So here in the ventilation, we use the word hyperventilation. And sometimes this overventilation, you may read into the your vomiting and all these things. In ventilation language, we call is the auto PEEP or dynamic hyperinflation. When lot of breaths keep on coming because you are triggering, then it can produce auto PEEP or it can cause the hyperventilation. That is the drawback of volume assist control and the patient assist control. So when this happens, then you make when you complained about that, then the manager of cafeteria said that you are having this complaint, then I can make another arrangement. So now we are moving to the fifth mode. Why fifth mode? Because we understood volume control, pressure control, 2, volume assist control, pressure assist control, 4th. Now fifth we are entering into that. What they made is they now make a water cooler besides your room. And they say your 3 bottle in the first agreement is 6 a.m., 2 p.m., 10 p.m. This bell will be still work, but what I will do is all the time this bell will not work. 1 hour before I will activate this bell. Activate means I allow to this thing. Before that, even if you trigger, the bell will not work. So this alarm bell will be activated 1 hour prior to expected delivery. Activated. If you wish, if you press during this activated period, you will get this bottle little bit preponed from the expected delivery to up to a 1 hour, but not necessarily at the 1 hour. Maybe a 20 minutes back, maybe 30 minutes back, and even at the same time. Even if you trigger it, don't trigger it, this bottle will come. If you don't do anything, then this bottle will come at the same time period, but no additional bottle will come. Understood? Suppose a 6 a.m. the fixed bottle has come. Instead of the 2 p.m., I triggered at a 1 p.m. Then the bottle which is expected to the 2 p.m., it will be delivered. Now what will happen at 2 p.m.? Nothing will happen. Nothing. Next bottle will come at the 10 p.m. only. If I trigger, trigger is not this thing is, then what is the difference from here to this thing? One thing we understood in the first beginning, there are 3 bottle only fixed time period. Now we are having a little bit of flexibility. We can prepone it. Of course, you can't postpone it. We can prepone it. That one thing we understand. But the another thing, what this? Now they are allowing you to go and drink water from the water cooler on your own efforts. And how much drinks, how many times you drinks, it's up to you. This is typically called, it is a synchronized intermittent mandatory ventilation. This is a classical one. Why the use word synchronized? Because when you demand, then it can synchronize that water. If you don't demand, then it will come at the fixed time period. Intermittent, mandatory because anyway you will get the 3 water, not more than that. Whereas in assist control, you can get n number of, because you just press the button and it will come. An intermittent mandatory ventilation along with the spontaneous breathing is allowed. This is called SIMV. And how it is different from the assist control? Because upper limit is fixed, 3 water on. In between, you can go for the spontaneous. How it is different from the control mode? Because you are having a flexibility to prepone the bottle, which wasn't there in the control mode, and simultaneously you can drink the water with your efforts. How many times it is immaterial. So this is the SIMV. Okay. With this, of course, this is one of the way. Now you are having one more agreement or there. Rather the mandatory and all these things, you said, look, don't send fixed bottle. I don't want. I just want whenever I press the button, you send the bottle. And I'll tell you how much volume is required. Probably 500 is good enough. Then I'll say 500, not all the time. Whenever I press it, send it. Press it, send it. Maybe 10 times in a day, 20 times in a day. If I don't press it, don't send it. And if I feel it is lesser for me, I will come to you. Till now, you understand what we are talking about. There is no interaction between delivery boy and you. Whatever you are having a complaint or change, you have to come to the manager. So similarly, you have to change the setting over there. So if you think your 300 ml is less, then you come to the manager and say, Now next time, all the time it will be 500 ml. You can't change in between. This is called the pressure support. So what we do is the pressure support. There is the initiation all the time by the patient. There is no ventilator initiation. So wherever when we talked about the assist control, the triggering would be time in the patient. SIMV, time in the patient, because time, anyway, this second is and patient in the form of, we will discuss the different type of triggering. The pressure support, only the patient triggering. Ventilator will not give. If this manager don't find any alarm, they will not send it to water to you. But there may be a little bit. So you make a safety feature over there. Though it is not the part of your mode. You said if 6 hours, if I don't alarm it, then activate my previous plan assist control. That means 1 liter water keep on coming. This typically arrangement in the pressure support is called backup ventilation. So now you understood this mode also, the pressure support with backup ventilation. Backup ventilation means if patient doesn't trigger up to a certain time period, we can fix it like a 30 second, 40 second, 1 minute maximally, because the ventilator doesn't allow according to your wishes. So maximally that period, minimum you can go for the 15 second. All this thing is, if you don't trigger anything, don't means you means the patient, then the assist control will be activated. Now even your delivery boy comes with this thing and you said, no, I am now ready, just bring the bottle when I drink, when I press this, because at this moment there is no communication with you and this delivery boy. He will not listen to you. He says, whatever this thing, you come to my manager and said it. What does it mean? When the backup ventilation is activated on the pressure control, pressure support mode, after that patient starts triggering, ventilator will not go back into the pressure support. It gives you a apnea alarm all the time, apnea ventilation, and convert into the assist control mode. Depend which assist control mode, would it be a volume or pressure? Depending upon what you selected beforehand, you have selected what should be my backup ventilation. It will go into that. Even after that, the patient become active and triggering, the pressure support will not be triggered. It will be triggered as assist control. So every time he will get a 1 liter rather than a 500 ml, which is a part of pressure support. That is the main feature of this thing, and nurses needs to know. Once the pressure support is converted into the apnea ventilation as a backup mode, you think my patient is in the pressure support mode. Actually, he is not. And whatever you are observing and ABG, whatever doing, you think this ABG on the pressure support, but it is actually in the backup mode which you selected on. So some ventilator needs reset button and the pressure support, and the few ventilator need go back to the setting and again select your pressure support. That is the full understanding of the pressure support. Okay. Now, to understand the more newer thing over there, triggering is the pressure, because you need to press the button so that whenever there is a change in the pressure in the airway, it triggers the breath. And triggering, where does it comes? Assist control comes the triggering action. SIMV is having a triggering. Pressure support is also having a triggering. But all these things, now I'm talking about the just triggering mechanism. Modes we understood. Modes, we actually understood the 7 mode. How come 7? Pressure control, volume control 2, volume assist control, pressure assist control 4 modes, SIMV volume preset, SIMV pressure preset 5, pressure support 6, 5 and 6, and pressure support 7. And you can combine SIMV with the pressure support also. So whenever you take the spontaneous breath, it can be converted. Now I'm talking about the triggering mechanism. So it would be common for all the triggering. Advancement. So one was the you are pressing. Now the advancement come, you make this your home enabled Wi-Fi. So you need not to, because like say for example in the gray winter you are in the bed and your triggering button is quite far away. Probably you try to come out from your bed, but you just again give up. This typically causes an inadequate, ineffective triggering, or sometimes extra effort. Sometimes you think, but you just wait for the 2 minutes, 3 minutes, and then go for the. So this is also called one of the delayed triggering. So these are the pressure-based ineffective triggering, delayed triggering that can happen. So what you did is now you make your mobile Wi-Fi available and application based all the time, mobile in your hand. So you need not to go. There is no delay, and relatively efforts are less. This is called the flow triggering. Instead of creating negative pressure in the airway, just change in the flow. When you little bit take the breath, and the change in the flow will give the command to the ventilator to initiate the breath. So this is the flow triggering. Understood? We are not moving further in the modes. Just I am giving you a mechanisms of triggering. So your assist control, your volume assist control can be a pressure triggered, can be a flow triggered. Of course, the flow trigger will be less effort for the patient. Similarly, SIMV can be volume preset, pressure preset, yes, fine, but they themselves can be a flow trigger or patient pressure trigger. And time trigger is also there, the SIMV. So the SIMV is having a 3 option over there. Pressure support, time is not there, but either pressure trigger or flow trigger. Okay, so this was the triggering. Now one more advancement in the triggering, like the technology is advancing. After Wi-Fi, what the new things happens? The new things happens like when the previously you have to go to the device physically. Later on, you are having mobile in your Wi-Fi enabled. Now next generation, what they are doing is they called Alexa, Siri. What you call is the voice-based command. So this is the voice-based command. Now I am discussing one more mode with this concept. So when voice-based command, where you are not physically active, but triggering is there in the patient, ventilator can start based upon the voice. So how I'm comparing this scenario into the mechanical ventilation means one electrode is inserted in the esophagus, lower esophagus junction, where the diaphragm is there, and this electrode or sensor can sense the change in electric activity of the diaphragm. And specific electric activity recognize the initiation rather than the patient effort before the little bit that. So that is called the NAVA. So NAVA is nothing but a most advanced form of triggering. Actually, it is a pressure support. Rest of the things is a pressure support. But how they trigger? They trigger with the electric stimulation by the diaphragm, not by the patient effort. So in this way, you understood the so many modes are there. Of course, today's topic is the basic. So basic, we can end up to the pressure support. Just the same concept, the NAVA, and just a fair good idea about the advanced mode. What is exactly the crux of the advanced mode? In advanced mode, this delivery boy becomes more intelligent. Till now, delivery boy wasn't participating any communication. Now, whenever you need and give instruction to the delivery boy, if this delivery boy carry out the instruction next time without going you to the manager, this will be an advanced one. What we call is the closed loop ventilation, where the patient and ventilator themselves interact without much involvement of the clinician. Like here. So what the manager worry or the concerns? you just keep that bottle timely replace over there, and I don't want any complaint. How you do it, how much do it, it's between you and that person. Similarly, in closed loop ventilation, clinicians set the goal, how to achieve it, whether to increase the respiratory rate, decrease the respiratory rate, tidal volume, all these things, or assist control, pressure support, all these things, they, ventilator and patient themselves, depending on the parameter, keep on changing, only give. This is the closed loop ventilation. And the most advanced one, when your delivery boy becomes so much intelligent, if you are having a certain demands, is carrying with you, with him only, immediately. Previously we are talking, you say something and next time he will complete, because he is okay, next time I will increase my bottle size or decrease my bottle size. Assume one scenario when you say, no, this is larger for me, just give me smaller one, or this small is too small, give me a larger. Immediately he is carrying the different type, immediately he take the out and gives you correction. That is the most advanced form of the ventilation, like a during breath ventilator correct the necessary requirement to the patient. So this is the concept, or otherwise I will not go into the detail. With this understanding analogy concept of the even at basic and advanced mode, with this concept, I hope everybody understood. Now the question comes, with this concept, you can't solve the question, you can't give the answer in your Viva. So now I am coming to the scientific way to understand these basic mode. With your understanding what I told you, this is the basic of your understanding, so that you understood. Of course, there are so many modes, we'll talk about the very, very basics over there. Now with this, the technical thing you must understand, whenever we describe any mode, we need to mention what is the trigger, what is the limit, what is the cycle. Now you understood the trigger, what command ventilator achieve or ventilator receive to initiate the breath, that is called triggering. When we say ventilator triggering and the patient triggering, this is the qualitative words. Here we'll give you a name of the physical quantity, like a time triggering, pressure triggering, flow triggering, and of course, except from the time, pressure and the flow would be a patient triggering only. Okay, so whenever you are asked in terms of this thing, is just giving this answer, a pressure support is the patient triggering, partially right, but not the very much correct in the language we are talking about. So in the language we are talking about the triggering. Similarly, limit either your pressure or flow, depending on, and preset is the pressure and the flow. Limit is like what limiting the quantity which the ventilator is not allowing to go beyond that. We'll talk about that. And cycling is, if you remember in the beginning of talk, C point, where the conversion from inspiration to the expiration. And that means what happens in the triggering? Triggering happens closure of the expiratory valve and opening of the inspiratory valve. So that the gases goes in, that is the triggering. Then the limit, up to that limit, this inspiration cycle will last. Now the inspiration cycle finishes. So what the thing happen? Closure of the inspiratory valve and opening of the expiratory valve. This is called cycling. So this activity called cycling, and who actually responsible for conversion from inspiratory to the expiratory, that is typically word called the cycling. Okay. This we already understood, then I little bit pause. Controlled we understood from our this assist control and supported with this thing is. So I escaped this, and now we need to little bit understand the mode of ventilation modes of ventilation with the scientific way of the flow, pressure, and volume with time, what is happening, and what typical these three things I told you you need to remember. What is the triggering? limit, and cycling in the particular mode. That actually suffices the mode. So spontaneous breathing, what happens? Spontaneous breathing is your flow, one side, the negative side. So initially your flow from environment to the patient, and from patient to the environment. Pressure is the negative, because you create a negative pressure during your inspiration, and then go. And volume means volume, whatever volume your lung is achieve, and again go back to the empty, achieve and empty. So this is the typical spontaneous. Now, before giving you a positive, you already understood your positive would be a pressure all the time positive. Of course, flow is positive. What do you mean by flow positive? Is the direction. So when we take inspiration, so then always from outside to the inside, so that would be a positive. And when from the inside to outside is the reverse direction, that would be negative. So flow, whether it is a spontaneous breath or the pressure generated, the flow would be a positive and negative, positive and negative. Pattern may change, we'll discuss. But major change happens in spontaneous, all the time negative pressure, and expiration positive pressure. So before volume, I'll go for the pressure, preset ventilation or pressure control. When I use the word preset, means it is applicable to the pressure control, pressure assist control, and pressure support also. Though I already mentioned there is no control mode now, but the theoretically you need to understand. In your practice, there is no control only. All are assist control. And when you give the muscle relaxation to that patient, that becomes a control. Because assist control is having an additional ability to trigger the breath by the patient, whereas control is not having this ability. So when you give the muscle relaxant, anyway, patient is not participating, that mode becomes a control mode. So pressure preset is having a classical flow pattern, which is called the decelerating pattern. And pressure is limit. And time, inspiratory time will determine how much volume has to be given. You understood? If I give the command to this, my airway pressure increase from 5 to 15. Okay. That ventilator understood. 5 is the PEEP and then 15. Now, how long this 15 should be remain? 0.1 second, 0.2 second, 0.3 second, 0.8 second, 1 second, one has to tell the ventilator. So we tell either in the form of inspiratory time or directly or indirectly respiratory rate with IE ratio. When you say 10 breath and my IE ratio is 1 to 2, you indirectly said ventilator how much time is inspiration. So now ventilator is triggered by time in assist control or control, because time, like how the time we can say 10 breaths per minute. That means every 6 seconds, ventilator start breath, giving the breath. Simple word. That is a triggering. Limit, you set 15 centimeter of water. Okay, ventilator 15 centimeter. That is also, they got the message. Now cycling means conversion from inspiration to expiration. You pressure control, you are giving the command 1 second of inspirator. So that time trigger, pressure limit, time cycle. So if somebody asks you about the characteristic of pressure control mode, then you will say time trigger, pressure limit, time cycle. How is the flow pattern? Decelerating flow pattern. Okay. Then describe the pressure assist control, time trigger or flow or oblique pressure trigger by patient. Limit, pressure, cycle, time only. Now at this moment, don't say time or patient. Patient can't determine your respiratory. Triggering he can determine. But how long? You already give the command 1 second means 1 second only. In between, patient can't make it as a 0.8 second and 1.2 second. Whereas triggering, he can trigger more than the breath. So that cycling will be a time only. So you understood now. Again, repeat patient pressure assist control, time oblique patient trigger, just for the sake of convenience. The patient you can convert into the flow oblique pressure. So time oblique patient trigger, pressure limit, time cycle. Okay. Now volume control. So usually we are having a tendency like a pressure and volume, you replace word pressure to the volume and everything goes fine. No, it is not in this thing. Is what I mean to say. Suppose if you ask a pressure control, then you will say time trigger, pressure limit, and time cycle. Then volume control, time trigger, volume limit, and time cycle. No, this is wrong. Why this is wrong, I'll not go into the detail, because machine can't understand in this way in the volume preset. So what they do is, if you set the volume and set the inspiratory time also, so this ventilator itself calculate. If I say 500 ml has to be given in a 1 minute, that means a half liter per minute flow. Simple. If I say a 500 ml should be given in 0.5 second, that means 1 liter per minute flow. So they calculate and they make the limit flow. And when I say for example, half 500 ml in 0.5 second means 1 liter per minute would be flow, but how long I will give? 0.5 second only. Eventually it comes to 500 ml. So that cycling would be a volume. If you understood this thing is okay. Even if you don't understood, just remember this thing is in volume control, time triggering, flow limit, volume cycle. Whereas in the pressure control, time trigger, pressure limit, time cycle. Volume control, time trigger, flow limit, and volume cycle. That's very important. And one thing is very clear by our school study. If one from the Boyle's law of the gases, pressure versus time, if you keep the one thing constant, another will be variable. So if you keep the volume constant of your this thing is and keep on entering the air into it, then the pressure will be changeable over there. So when we keep the volume constant, then the peak and plateau pressure will come, because pressure will be variable. When we keep the pressure constant, then the volume will be variable. And that is the problem with the pressure control. Why it is not popular in the this thing is because suddenly your lung becomes stiff, then the pressure will be reached, whatever your target, and they become stiff. So quickly they reach, hardly 200 ml volume will be given. And the more safety is required for the volume. Pressure also requires safety, but more is for the volume. So that's why volume are. So when you keep the pressure preset of pressure control, then the volume will be variable. So that is the basic principle. Assist control, I guess now you understood. Again, the same volume assist control, you will have a same thing. Volume assist control, time trigger and patient trigger, flow limit, volume cycle. Pressure assist control, can somebody just memorize themselves? Time trigger and patient trigger, limit, pressure limit, cycle, time. Flow pattern, decelerating pattern. So volume assist control we understood. Now SIMV, as I told you, SIMV can also be a two types. SIMV is the pattern, how the triggering is there. You understood in the initial ventilation analogy. This is the same analogy where your person who is residing in the room having a water cooler beside that. Water cooler means spontaneous breathing. So SIMV is basically mandatory breath. In between, spontaneous breath is allowable, and spontaneous breath is a spontaneous one. It cannot be categorized a volume preset and a pressure preset. But mandatory breath you can categorize whether it is a volume preset or pressure preset. If it is a volume preset, then follow the same rule. Flow would be constant. Flow limit is there. So SIMV can be of two types. In fact, three types. I'll say you how the three types. SIMV volume preset. Of course, in between spontaneous breathing is allowed. SIMV pressure preset. In between spontaneous breathing is allowed. And SIMV plus pressure support. wherever your spontaneous breathing rather than the pressure support breaths come into those. So this typical screen you can see, it is a, I guess everybody must understood, this is the SIMV volume preset because flow is constant. Now, in between you will find the pressure is -1, that means this is a spontaneous breath, and this time flow is decelerating. That means it is a SIMV pressure preset with a spontaneous in between. Pressure support, little bit tricky over there. Pressure control, you people understand. Triggering is time. So it is a support mode. There is no participation of ventilator to initiate the breath. It is the patient themselves. That means the triggering is either flow or pressure. Okay. Decelerating flow, of course, this is the basic principle. All pressure preset is a decelerating flow. So that is also there. So patient starts the breath. You set the ventilator with the upper limit of this thing is, you don't set the respiratory rate because patient wants 10, 20 themselves. But how long this pressure will remain in inspiratory phase? I'm just comparing from the pressure control. You keep the 15 and you gave the command to the 1 second. The 1 second they will remain this thing and the come down to the cycling phase. That's why we call this a time cycle. But in pressure support mode, when you see the ventilator, you don't set anything. You just set the low pressure upset. Low pressure is the P, upper setter FiO2, and that's all. So you set the upper pressure. How long it will remain? Actually, you're not giving any command to the ventilator. That is the PSV. So what exactly happened here is when breath starts, it's coming from ventilator through the patient lung. So patient lung, once they are emptying, they gradually start filling up. Once they're filling up, the decelerating pattern goes down, and once your decelerating pattern reach to a certain level, that ventilator understand now the lung is almost filled, and they convert from inspiratory to the expiratory cycle. So this one, that's why it is not reaching to the baseline 0. So how do you describe the pressure support in the form of triggering, limit, and cycling? Triggering is pressure or flow. Time is not here because you are not setting any respiratory rate. Patient themselves, patient by the pressure or flow. Limit, pressure, cycling, flow. So classically, we just for the rhyme way, we say flow, pressure, flow. FPF. Flow trigger, pressure limit, flow cycle. How we can say flow cycle? Because before reaching to the 0, when it's reached to the, say for example, 10% of your peak inspiratory flow, then the ventilator convert into the expiratory. And whereas you see the pressure control now, every time it reaches to the 0. Because time is allowing, you set the inspiratory time. Every time, whenever you see any pressure assist control, it will reach to the 0. So just by seeing the flow pattern, you don't see any upper panel of your screen of your ventilator. Just seeing this thing is, you can say either my patient is on the pressure assist control. Of course, control is not there now, or pressure support. How you can say pressure? Because decelerating flow. How you can say pressure support? Because it's not touching the baseline. And mind it, I am talking about the inspiratory cycle, not the expiratory cycle. If expiratory cycle not touching the baseline is having a different meaning, which is not the topic of today's discussion. So you understood, and the same problem with this pressure support, which I already narrated with the pressure preset. If you keep the pressure set, then if lung becomes stiff, volume goes down. And if lung becomes very much elastic, your volume goes up. Both the things can be very dangerous. Say, for example, everything is fine. Suddenly, your patient's having a significant secretions in the lungs, significant. So it allowed the pressure to rise. Ventilator understand, okay, my limit has achieved. You assume this limit, it allows to go to the volume, but volume is not achieved because these create a resistance and the pressure will be high up to a certain level. Then the volume go into the expiratory phase. So eventually the less tidal volume will be given. That may cause a dangerously hypoventilation. Patient might have cardiac arrest for this thing. So it keep on happening every breath. You are thinking I am giving a 400 tidal volume with the assumption of the 15 P maximum or plateau phase for 1 second and goes to the 400. But P plateau reaching to the 15, but stiff are there, hardly 200 ml reach to the lung. And every time 50%, it remains for the 15 minutes, half an hour. Your CO2 becomes so much high and it may cause the cardiac arrest. Other way around, suppose some patient come with the pulmonary edema and not able, somehow you selected a pressure preset. So you give the 30, 35 pressure because it require a little bit higher pressure just to achieve a 300 tidal volume, because very less, so that you have to keep the pressure high at the 300 tidal volume. Over the time, and then you leave the patient. But obviously you are treating the patient with the medication and ventilation when it's reach what they are, maybe inotrope, dovitamin, all these things. So your treatment getting in the right direction. What happened? Diuresis happens, and now the lungs, fluid from the lungs in the form of pulmonary edema, over the time period, they get resolved. Now your lung becomes more and more better in terms of elasticity, because water is now coming out, the stiffness goes over there. And if you are not around with the patient, same 30 limit of the pressure previously when you receive the patient was producing a 300 tidal volume over the 2 hours or 3 hours, depending upon the how good your treatment. If treatment is very good, then what happens over the 3 hours, the same 30 centimeter water pressure will gives you a 500 tidal volume, 600 tidal volume, and more the patient becomes better, this risk keep on. And if lungs becomes absolutely like a previous one in the 6 hours and nobody is seeing this patient, probably goes to the 900 tidal volume, and the pneumothorax in patient may die. Why patient die? Because he was getting better. That's the reason for the his death. So combination of, because he's getting better and nobody is seeing and actually take the call to reduce the pressure to see the volume. So that's why both the things can happen. Pressure preset, it can lead to the low tidal volume, it can lead to the higher tidal volume. This I already discussed. One can combine with the assign with the PS, and one can easily see. If you see nothing is on this thing, you can easily see this pink color flow is in the constant flow. Flow is only the, you can say upper and lower, both the things, because flow is the positive and negative from the patient to the patient. When you see your inspiratory is the straight line flow, that means it's a volume preset, and pressure is always decelerating and it is not touching the baseline. That means it is a SIMV volume preset with the pressure support. So all these things I already discussed you why it is not touching, and now you can see this also, this one. Both are decelerating, this and this, all three breaths in the flow pattern. Mind it, whenever you comment on the mode of ventilation, always see the flow first. Flow is constant, volume preset. Flow is decelerating, pressure preset. Now, how you can differentiate pressure preset means the pressure assist control also and pressure support also. When decelerating flow touch to the baseline, it is a pressure control or pressure assist control. Or if it is not touching to the baseline, before that is cycling, and it is a pressure support. So now you can easily say this is SIMV volume preset, that is a mandatory breath, plus pressure support breath. And pressure support breath is always initiated by the patient. So number of pressure support you can't determine. You can determine the SIMV numbers, which in the beginning I talked to you, upper limit will be you can little bit pre-pone the bottle, ultimately you get a 3 bottle only. So if your SIMV set the 10 breaths, so it will give the 10 breaths only. The rest of the things will be pressure support. CPAP similarly, same, this thing is constant and constant pressure. I'll not go into the detail. Dual control at this moment because it's an advanced mode. So if you people want to have a certain advanced mode, please write in the chat box in the subsequent coming lectures. Not obviously in the month of August, which I already planned. So if you want a certain important, so today's only you can write in the chat box. So advanced mode, if you like, if you want, then we'll discuss this dual control. As if now I'm not touching it, and finally reach to our few last slide over there. This is like we are having examination of the patient. Similarly, in ICU, we must have a predefined way or checklist how to examine the ventilator. So this is my proposal. You can take the snapshot of this slide. And if you understand that, it's very good. Even if you want to make a certain changes according to you, please do that. But every day follow the same pattern of examination of the patient, examination of the ventilator. So what I usually do in my unit is screen the patient at a glance. Any patient on the ventilator, you just see the patients. Suddenly you can find there is a problem, almost near cardiac arrest and all these things. So obviously you need not to, just at a glance see the patient. Now second, come to the ventilator. Screen the ventilator display upper ribbon and look for alarm. I'll 1 or 2 slides I give you exactly photograph what I mean. The most upper part of this thing is because there are certain most important alarm and information is actually displaying over there. They are meant for clinician to know, and once you reach, that is the right time. At least in between, obviously one has to see, but at least once you reach to the ventilator, at least see what the ventilator want to say you something. Then comes to the numbers. So at a time you just concentrate on them, just see the numbers, whatever numbers. Typically numbers displayed on the ventilator screen is having a 3 category. Either they are setting numbers, like a setting numbers is FiO2, PEEP, tidal volume, inspiratory cycle, I ratio. Sometime it may be your pause time. These are numbers, but these are the setting numbers. Second is the monitoring number, like a P peak, P plateau, because you don't set the P peak, you get the P peak, you get the P plateau, you get the compliance, you get the FiO2. FiO2 is having a 2 option. Once you set it, and actually what is delivering. Respiratory rate is also both the things. So you should be very clear which respiratory rate seeing. It is the setting number or displaying number or monitoring number. You set 18, monitoring showing a 1 is a 22. Then you understand these are the things. And third is the alarm setting number. So as if now whatever you see the number, your mind must be trained to see which number I'm talking about. I'm seeing this thing is this my setting number? Is this my monitoring number, or this is the alarming number? And based upon that, this is just a proposal how to go about that. I'm not talking about the interpretation at this moment. Next is the graphics. Whether you understand or don't understand, again, if you require the one lecture on the graphics, please do write it. As of now, I'm not planning little bit the advanced part of ventilation. If you are really interested in simplified version, I can prepare the class for the graphics. Usually nurses avoid the graphics or there, but we can make a little bit. But in this, if you want to understand or don't understand, or even you understand or don't understand, just see it. This is my humble request. Ventilator graphing, just see scalars or loop. Scalars 3. Pressure, flow, time, all are against the time. So pressure versus time, flow versus time, volume versus time, because that's mandatory. Last few slides are based on that only. That's from there we actually decipher which mode the patient is in, rather than seeing on the panel. Similarly, loops, pressure versus volume and volume versus flow. Don't worry, I'm not going to describe these graphics right now. But this is a proposal. You have to just see it. Whether you understand or not, that's a different issue. So my first, this part, screen, ventilator, patient at a glance, you can see the upper part. I am talking about this upper part. You see here airway pressure high, disconnection detected. They are the different ventilator having a provision. Either it is active alarm, so there may be color coding, and the audible alarm is also there. If it's not active means it happens, it's corrected, but nobody has reset it. Means it happens some point of time. So you are having some idea about what's going on. And upper panel include both, right from left to right. This is the alarm only. When I say upper ribbon, that means this is the now children. This may not be adult. So those those ICUs sharing the ventilator with the pediatric wards, pediatric intensive care, there's a higher risk for both the population, because the ventilator keep on changing from there. So there may be a pediatric mode applied to the adult, and similarly. This is the set numbers when I talked about. This is the monitored number along with the certain alarm also. And this is the graphics. So three things, again repeating: upper panel, numbers, graphics. In graphics, these are the, again, the three graphs, two loops. So with this, I end the lecture, and we almost reached across the little bit time. So thank you everybody for patience learning. Any question? Quickly, we can take this few questions.
Good evening, sir. I think my voice would be audible now.
Yeah.
So sorry for the delay.
Swati, do you see any question in the chat box or few final comments? We give just 2-3 minutes more to our listener. Even somebody wants to ask the question directly, can Deepa, we allowed unmute them and they can ask the question directly, or
Deepa,
they can write in the chat box.
I don't see any questions as of now, so there are still, I think we can wait for some time. Any kinds of doubts, please let us know now, or you can just write it in the chat box. No questions. I think they have understood the topic really well. The graphics and all, it has been an example. We also have learned the same graphics throughout the entire 3-year course.
So when we close the session, this thing is
Deepak,